Hello, welcome everybody to this webinar. It's a pleasure to be here today. So I'm Nancy Byatt. I'm a psychiatrist and I'm at UMass Medical School. I have a few roles. I direct the statewide program MCPAP for Moms, which is the Massachusetts Child Psychiatry Access Program for Moms, which I'm going to talk about today. And the other role I have is I direct a center called Lifeline for Moms that I founded and direct. And I also direct the Division of Women's Mental Health within our department here at UMass. And so what I'm going to talk about today is population-based approaches for addressing perinatal mental health and substance use disorders. Go to the next slide here. So perinatal mental health affects everybody. And this is actually a picture of my mother and her mother when my mother was a baby. You can see that it's old and blurry because it's from the 1950s. And as you can see from this photo, they don't look particularly attached or bonded. My grandmother is holding my mother in this very awkward way. They're not looking at each other. And so, you know, I was like acute. I've always been aware of the importance of perinatal mental health because my mom, because of some unknown psychiatric illness that occurred with my grandmother, my mom was actually sent to go live on a farm with a family she'd never met for 6 months during her first year of life. And so for me, it was always really clear about, and I watched growing up, I saw my mom struggle with that and kind of work through all of that, disrupted bonding or attachment with her mom. And, and no one ever, at that time, nobody knew about it. I mean, my mom was sent to go live on a farm because we knew nothing. So if you fast forward, so I've always been aware of how important this is due to my own, family experiences and my mom's experience. And, to bring us back to about 10 years ago is, when I was a fellow doing consultation liaison, meaning kind of doing consults with frontline providers or clinicians in a medical setting, it was very clear to me that, even though it's 60 years later, major gaps in perinatal mental health care exist. And I'm going to give an example how our systems really have a lot of opportunities to be able to address perinatal mental health. And when I use that term, I'm referring to mental health in pregnancy and in the first year postpartum. So when I was a fellow at Brigham and Women's, a woman presented to me who I'm going to, call Kai. And, Kai presented in her second pregnancy and said, I really don't want to have the experience I had in my first pregnancy. And Kai presented and reported that she gave, birth. It was a planned pregnancy in this particular case. And she said that, throughout the end of the pregnancy, she started feeling down. She wasn't feeling herself. And the baby was born and she said the baby felt like an alien to her. She said, she said she didn't fall in love with the baby. She said she was essentially a black hole for that baby's first year of life. And she really felt like she wasn't present for the baby. And it wasn't. And, it was clear that the impact that she felt that had on her and her baby's bonding, that she really wanted to avoid that in her second pregnancy. And there were some things that really struck me about when Kai described what happened with her and her baby. One was that she had absolutely no idea she had depression. It wasn't until a year and a half later when she eventually came out of it on her own or began to recover that she realized, well, I wasn't myself. That is not an expected experience of motherhood that you feel that way. The other thing was that nobody asked her about it. Nobody ever screened her. Nobody talked to her about it. She was seen in medical settings so many times during pregnancy and the postpartum period, and no one ever mentioned anything about depression, despite that it's actually twice as common as diabetes in pregnancy. They asked her a bunch of other questions, but nothing about mental health. And so, it really struck me that what a missed opportunity, for Kai, because that could have been addressed, it could have been prevented, all of that. And also we have countless cases like this that occur across our medical systems where, mental health isn't integrated or historically hasn't been integrated in mental health care. And there's so many gaps and so many opportunities in medical settings to be able to address, mental health and substance use disorders. And so, I've given a few examples from my, personal professional experience, and, the data bears this out. So perinatal mental health and substance use disorders are common. They occur in up to 1 in 5 women. They're undertreated. Even specifically for depression, even if a woman screens positive for depression, less than a quarter of those women are even going to get to an initial mental health appointment. And we also know, so it's no surprise, although it's it's deeply concerning that they're a leading cause of maternal death. So mental health and substance use disorders are on par with infection as the leading cause of maternal death. And also they are on par with infection as a leading cause of preventable death. They are a leading cause of death in general, but they're on par with infection as a leading cause in America of preventable death. So clearly there's a lot of work to do here. Fortunately, this is being recognized. Healthcare systems are understanding and realizing that they need to address, and our professional society, policymakers, other key partners at the systems level are recognizing that healthcare systems need to address perinatal mental health and substance use disorders, and are the healthcare system itself. So there's many recommendations to screen during this time period, and almost all those recommendations state that if someone is screened for mental health or substance use disorder, it needs to be followed up by a appropriate response to that positive screen. You fast forward when we first started doing research on this years ago, and individuals would hear, well, we literally had someone in one of our focus group tell us, well, you're depressed, good luck. They would say, they said, you're depressed. There's EPDS was positive, which is a depression screening tool. And they said, well, you have a happy, healthy baby. What else do you want? Clearly, that's unhelpful. If we're going to address these things and we're going to screen, we have to do it with an appropriate response. That screening alone is not, it can actually even be harmful if it's not it's responded to appropriately. So we got to follow screening with interventions that provide or link individuals with care. So when we think about the pathway, what we refer to in our research team as the perinatal mental health care pathway. You really have detection, which is a screening that needs to be followed by assessment, initiation of treatment. That treatment needs to be adequate. It needs to be sustained. The symptoms need to improve, so you ideally have improved outcomes. And along there needs to be a process for engagement and connection. And our thoughts around this pathway have evolved. And as I describe a bit of our story with the research that we've done, the programs we developed, I'll talk about how there's some other pieces to this that need to be integrated in. So you might think, well, how do you do that? I described these really cases where there were major gaps. How do we begin to build the capacity of these medical settings? Because, if you go back, about 13 years ago now, when we first started doing this work, and we heard from women that the provider said, well, you have a happy, healthy baby. What else do you want? And the women and the perinatal individuals really felt like even if they were screened positive, it wasn't heard. They felt stigmatized. And even if the provider did screen, they didn't know what to do. What we heard from providers around that time was, we need a lifeline. We need someone to call. We don't know what to do. So in response to this, and based on a lot of the qualitative research we've been doing, and what we heard from both individuals' lived experience and clinicians working in the community, seeing pregnant and postpartum individuals, we heard that they needed help. They needed someone to help them do this, because they weren't going to just do it appropriately, so because this is complicated. It's not easy to be providing mental health treatment. So we created MCPAP for Moms. I'm the founding medical director of that program, and it's a program that really aims to build the capacity of the medical community to address mental health and substance use disorders among pregnant and postpartum individuals. And we do that through three core ways: education, consultation, and resource and referral. So education, one of the things we do there is we provide training and toolkits. Through a lot of our research, we developed, for example, this is an example of an antidepressant treatment algorithm where they told us, we want to know what to do. We need algorithms. We need to know exactly what to do. Particularly, it'll be providers who are surgeons. They want it to be really concrete. So we created ways to provide treatment and to help build their capacity. This is an example of our website. We have all this information is publicly available. We also went and did trainings at birthing hospitals and practices to help educate them on how do you respond to that positive screen? How do you have that conversation using a strengths-based trauma responsive approach that you're going to help to engage women in participating in treatment? And the other thing we do, so then, we educate them in how to do that, but then what do they do? Because we know that education is necessary but not sufficient to change practice, clinician practices. So what we do is we provide consultation. So telephone consultation is what we think of as the primary currency or the engine of this relationship, and the engine of the currency of the relationship and the engine of the access program. So give an example, if a clinicians and out there seeing a patient and they have somebody screens positive for depression and they're not sure what to do, then they would, they can call we have an 855 number this is a statewide program. So any clinician working with serving a pregnant or postpartum individual, any of them can call us throughout the state. They call, they reach one of our resource and referral specialists. They would then page us, and we would then call the provider back, the clinician back, and have a conversation about what to do. And I'll go into a little more detail about how that works. So I'm going to give a couple of examples. I was covering the phones on Monday. I'm actually going to use Kai as an example here too. So, if we think about Kai, right, ideally her practice would have been trained in, okay, this is how you address depression. You screen a couple times in pregnancy, you screen postpartum, and they would have felt like, okay, we know what to do. We feel like we can screen because we know we can call. And so ideally, I was on covering the phones on Monday. I cover the program one day a week. And one of the provider called on Monday, and they were asking, it was a patient that had a history of depression. This particular patient had been on an antidepressant in the past. The patient had stopped it. The provider was wondering what to restart. She was wondering about whether that antidepressant was safe in pregnancy. We had a conversation about, you want to use what's worked in the past. It was a pretty relatively, they had a very specific question. We discussed that, and we got off the phone. The other thing that often happens during those is another example is somebody called, and it was a more complicated patient that in this case had a history of, she hadn't responded to an antidepressant before. The provider was really just not comfortable providing mental health care. And so they said, I'm happy to do it. I just need someone to see her. So in that case, we recommended a face-to-face evaluation. And we are going to evaluate the patient, do a one-time consultation. And after we evaluate that patient, we will give a note to the provider and also call the provider and let them know our recommendations. And in that, we really integrate in, obviously if medications are indicated, we make those recommendations. We also make recommendations around, we work for any psychotherapy that's needed. If other types of therapy are needed, we make recommendations around other community supports. We also make a lot of recommendations around other adjunctive interventions, such as exercise, sleep, hygiene, things like that. So we make a lot of we work hard to make a holistic approach and be making holistic recommendations. The other thing that can happen is another example from Monday is a provider called, and this patient had a relatively low score. I mean, a positive screening score, but not particularly high, wasn't consistent with moderate or severe depression, more mild. And the patient had a preference for psychotherapy. The provider didn't think therapy was indicated. There was a lot of psychosocial stressors. In that case, we referred to the community. The patient had been trying to find a therapist, couldn't. Our resource and referral specialist outreaches the patient to refer to the community. So that's a lot of what we're doing as well, is helping link with resources in the community. I want to make a note that this is different than telepsychiatry. Telepsychiatry is great because we do a lot of telepsychiatry for moms, particularly since the pandemic. We do most of our face-to-face evaluations now over virtually. However, the way that we're different is we never take over and prescribe. With telepsychiatry, it's really the format that's different, and that you're doing it virtually, but you could still be prescribing and providing direct care. We don't provide direct care. Our goal is to build the capacity of the medical settings to do that, leveraging us as limited resources so we can increase access to care. We don't ever take over care or prescribe ourselves. We do follow-ups. I did one on Monday because the patient still hadn't been able to access a psychiatrist, and the provider, needed her. She had some questions, and so in that case, I saw her again. The provider that I was doing the consult for was still prescribing the medication. So I talked a fair amount about obstetric providers. They're the providers who use our program the most. We, although we take calls, as I mentioned, from any individual working with pregnant or postpartum individuals. And we also have a toolkit, and we take calls from pediatric providers, and we really encourage pediatric providers to be screening at well child visits. And we also get a fair amount of calls from psychiatric providers as well. And those continue to go up. So the other thing we do, as I mentioned, is we provide resource and referrals. So what we do here, as I mentioned when I gave that example, is we're linking individuals with therapy, support groups, and other community resources. We work with an organization called William James College Interface to do that. And the goal is we're supporting the wellness and mental health of perinatal individuals. And we're doing that with, a lot of times we're not necessarily recommending medication treatment. I'd say actually the vast majority of the services we provide don't involve any medication treatment recommendations. The other thing I want to point out when we think about these programs is engagement's really important. People think you build it, they will come. Unfortunately, that's not the case. That would be great, but unfortunately it doesn't work that way. There really has to be, for these programs to be successful, this has been our experience, and I'll talk more about what's happening nationally, but there absolutely has to be a very, very proactive approach to engaging the clinicians in the community and the medical community in using the program and in providing care. So, MCPAP one of the unique things about MCPAP for Moms is that it's a scalable model that leverages limited resources. So we provide, we have 3 hubs throughout the state, at Brigham and Women's, at UMass Medical School, and at Bay State Health. And we have 1 psychiatrist that covers the state, so between 5 and 2.5 resource and referral specialists. Actually, we're going up on that because our utilization is going to be so high. That'll be going up very soon. But that's pretty limited, right? I'll give the data. So we've served since we've launched in July of 2014 with 1 FT of a psychiatrist that's split between 5 across the street that covers our phone line from 9 to 5. We have served over 12,000 perinatal individuals. That's a lot. We've been around for about just 7 years. It'll be 7 years in July. So if you consider that, I myself could never have seen 12,000 individuals over a 7-year period, me as a full-time, if not working as a full-time perinatal psychiatrist. So it leverages us as a limited resource. But as you see, a lot of what we're doing is therapy. So 10,000 of those we do resource and referral, and medication's only involved in actually less than half of them. And a lot of these provider-to-provider encounters don't necessarily involve medication recommendations. The other thing I want to point out here is that of the individuals we serve, you can see it's the vast majority we don't see for consultation. So when we do these consultations, we're able to get them in very quickly because the vast majority we manage over the phone, and we help the frontline clinician provide care themselves. When it's more complicated, we see them for a one-time consultation. So typically for one-time consult, we can usually get them in within a week or 2. And, we've enrolled, since we started, 162 practices, which is 78% of the practices in Massachusetts. And of those practices enrolled, more than half of them are utilizing us. And so I mentioned that, the vast majority do not have an evaluation where often there are medication recommendations involved in those evaluations. And on average, we're serving 300 to 400 individuals per month. And this continues to go up. Actually, last month was our first month where we served over 400 individuals. The need has gone up, I would say, pretty dramatically since COVID. The access has been harder, the prevalence is going up, and our utilization has gone up. We used to be 200 to 300 patients per month. Throughout the pandemic, it's been 300 to 400. Last month, we saw 100. We served 405 patients. And the other thing I want to point out when it comes to these, MCPAP for Moms is that one of the things we note is that the culture that as we have been around for longer, the ability of the frontline clinicians to treat changes. When we first started, we were very purposely focused on depression because that was palatable at the time. Back in 2013, people said, no one's ever going to address depression. You're never going to go to BC to do that. They're never going to do it. They thought it was like a pipe dream. And at the time, it was a real culture shift. We would go to practices, and it wasn't an easy sell at the time. So we very specifically were focused on depression because we knew we'd alienate them or scare them if we were sort of proposing to them to do more than that. But then as they thought, okay, we can do this. It's not that hard, and it's not like there's access to psychiatrists because it takes too long. So then they started addressing depression. Around that time, there was recommendations from the American College of OBGYN and other policymakers that OBs need to be screening. And so the field wrapped their mind around it and really got behind it. And then we noticed they were calling about bipolar disorder. Our MD PhD student, Grace Masters, who just did a very successful defense of her dissertation in the spring, is focusing on bipolar disorder. And what we've seen over time, and Grace has a paper that she just submitted around this, is that over time, the more they call, particularly for face-to-face evaluations, the more they actually treat more complicated illness. So for example, i.e. bipolar disorder. So when they use resource and referral, you see a bit of a bump up in them treating more complicated illness. You see that bump up with phone consultations. You see even more with face-to-face consultations. You might be wondering, well, why are OBs addressing bipolar disorder? That's a great question. Ideally, individuals with bipolar disorder would be able to see a psychiatrist, but the reality is there's often a several months wait. So we can see them, or even psychiatrists in the community may not be comfortable doing that. So, because they don't feel comfortable prescribing meds in pregnancy. So what often happens is we'll see them for one-time consult and they'll be prescribed after we've done that evaluation. And then we can even see them for follow-up visits. Particularly during COVID, I've been seeing a lot of us have been seeing individuals for follow-up visits while the frontline provider continues to prescribe, and we continue to sort of hold their hand in doing that. We had an expansion in 2018 focused on substance use disorders that Lena Mattal, our associate medical director, heads up. We get increasing calls about this. And also, beginning in 2020, we've had a focus on health equity. And I'll come back to that a bit in a little bit more detail. I think that's here. So one of the goals of a key goal of MCPAP for Moms is to provide equitable access to mental health care. When we first began it, as I mentioned, it was really a time when people thought, as I mentioned, no one's going to address depression. So we were pretty focused on, okay, let's increase access to mental health care for everybody. And I think we thought, well, and we are insurance blind. So no matter what insurance people have, we don't actually bill. Doesn't matter the insurance, it's paid for by the state. So in that sense, we increase access to care for everybody. But the reality is, depending on people's socioeconomic situation, depending on their the community that they're from, there's going to be different barriers to mental health care. So what's become very clear to us is that, and what we've been focusing on, particularly in the past year, is that we need to take a really proactive, anti-racist, and and culturally responsive approach to really being proactive to make sure that we're really providing equitable access to mental health care and responding to the needs of communities as we need to. So when we think about MCPAP for Moms, it really focuses on this sort of middle circle here, the care team, collaboration, integration, systems and settings. But, there's all these other pieces happening around that. And I think for the first, 6 years, we were really focused in here. And I think, we've increased access. That's great. Now we're really focused on how do we now integrate these other pieces, social determinants of health, and addressing structural inequities and biases as part of the model. A lot of learning to do there. We've made some headway, and I'll go a little bit into it here. So this could be a whole nother webinar, but I'll give a kind of brief example of it because it's so important. So one of the things that we've really been focusing on is really having equity and justice be at the forefront of our vision, values, and services. So one example, just giving a few examples of how we've done this. We've created a liberated space to address individual contributions to racism, foster anti-racist action. We've read articles, and we have a meeting once a month where we talk about this as it relates to our clinical work and our interactions with clinicians and the individuals we're serving. We're applying an anti-racist lens to all of our processes, including data collection, evaluation to address inequity. So we just added race and ethnicity as a field to our data collection. So for example, we can look at, we know the distribution of race and ethnicities in Massachusetts, and is that who we're seeing, or are there inequities there? And then we can use that, because I do believe, as a researcher, if you don't measure it, you can't improve it. So we've added that. We're also looking at all of our products, our dissemination materials, our website, to make sure that they're promoting belonging and highlighting, promoting belonging and inclusivity. And that when we're educating, we're highlighting racial inequities and other inequities and, giving and working towards helping address them. And we're also wanting the clinicians and the individuals we serve to have equitable access to us, and including this in our trainings and services. And then we're also working intentionally to collaborate, engage with communities and systems to address barriers and promote equity and justice. So for example, we are just working with the state to try to get to work towards getting some funding so we can have a collaboration with PSI. MCPAP for Moms is provider facing, right? So providers can call us. If a patient calls, we actually tell them to call the provider. We don't take calls from patients. So we're working with PSI, so there's no wrong door, so that we can, help amplify PSI in the community and help amplify and disseminate their work. And then also individuals can call PSI so that there's no wrong door. So in kind of summary with MCPAP for Moms, all individuals across Massachusetts have access to evidence. Pregnant postpartum individuals have access to evidence-based mental health and substance disorder treatment because any of their providers can call us. And we're excited that it's served as a model for other states. And just to briefly talk about the cost. Untreated perinatal mood anxiety disorders come at a high cost. They're estimated to cost $32,000 per mother-child dyad. In the state of Massachusetts, where we have about 72,000 births, if you consider that without a program like MCPAP for Moms or another similar program, less than a quarter of individuals are going to get care. If that costs $32,000 per dyad, that costs over $345 million per year. Our program costs just less than $14 per year, just over $1 a month, and about $1 million per year. So it's a lot less expensive than untreated illness. And I also want to add that 50% is recuperated through a legislated surcharge to commercial insurers. So in 2015, due to wonderful, advocacy from individuals with experience, and also on the child access program side, there's a pediatric access program in our state that our program was initially built off and modeled off of. 50% of the cost of the program is recuperated back through the commercial insurers. So 50% of our patients are publicly insured, and of those, and 50% are privately insured. So of the ones who are commercially insured, the health plans pay a surcharge that's proportional to the amount of their patients that are commercially insured, or the proportional to the amount of patients who are served by the program. So generally that's about 50%. So 50% of the cost comes back through this surcharge. It makes the program far more sustainable. And we're excited that it's serving as a model for other states across the U.S. MCPAP for Moms inspired Congresswoman Catherine Clark to put forth federal legislation for other programs like it, and that was passed into law as part of the 21st Century Cures Act, and that funding was appropriated, and there's now HRSA grants for 7 programs throughout the country to have programs modeled off MCPAP for Moms. So this is just a visual of the programs. There's now 17 access programs that cover over 1.4 million of the 3.5 million U.S. births across our country. So we're covering, over a third of the births throughout the country with these collective access programs. And, what we're finding is that as these access programs are being implemented is that they need to be tailored for the region that they serve. So, for example, when we think about, Massachusetts, we have training, consultation, resource, and referral. In Washington, they have training and toolkits and consultation. They don't do resource and referral. This is a funding. In Wisconsin, they do both of these too. They do training and consultation. So they're implemented in different ways in all the access programs throughout the country. I mean, we're just thinking of Montana, for example. They have a lot of rural communities. So Montana is working really hard to engage indigenous communities and clinicians working with indigenous communities, which is very, very different than what another state might be doing. That, Montana has a huge, they don't have any academic medical centers in the whole state, and they also have a huge rural population, which is very different than Massachusetts, where we have tons of academic medical centers and much less. We do have rural communities in Massachusetts, but far less than a lot of these other states throughout the country. And also there's the context. I mentioned, I mentioned some of the, around, particular programs having a focus on, for example, indigenous communities. There's also the context of legislation, the funding, and if there's complementary programs. So all of these access programs, it's really one size fits none, where they need to be tailored based on the region, based on the legislature, based on what their priorities are, and so forth. The goal is still increasing access to perinatal mental health care. The way that's being implemented needs to be tailored to the environment that each of these programs are in. So, these are really being implemented and funded in various ways. 7 of them are funded through the HRSA programs. Others are, PAL for Moms, for example, in Washington, it's funded through, it's a legislated funding. So, but there's different ways of these being funded throughout the country. Dignity Health is funded by a foundation grant. So there's different ways of funding these. And so what we did was, as these programs were popping up throughout the country, we created a network of these access programs. And what this network aims to do is to improve maternal and child health care through access programs. Because what we found was that people kept calling us and saying, well, how did you do that? We want to have one like that. And we provide consultation as well to individuals around how they can develop their access programs. We also have the network. And the goal of the network is peer learning and resource sharing, and also program evaluation. So we have interactive meetings once a month. We have some subgroups. We have, for example, an equity incubator group to help all of the access programs work on, promoting equity within their programs and within their states. And we also facilitate program evaluation. And if you're interested in more information, our website's there at the bottom. The other thing that we're doing is we're currently doing a study. I'm dual PI with Tom Mackey from Rutgers on this study. He's the corresponding PI. And we're looking at the synergy between access programs and MCPAP for moms. We're conducting the study, which is evaluating lifelines for moms. What we're doing in the study is we're leveraging the synergy between MCPAP for moms, Lifeline for moms, and this study. So what we're doing in the study is we're evaluating the comparative effectiveness of different program models. So I mentioned how, for example, Massachusetts has different way of implementing than Washington. And New Jersey also has a different way. So we're comparing Massachusetts, New Jersey, and Washington to look at how are these programs best implemented and which approach is most effective in engaging individuals in treatment. And we're doing that using Medicaid claims data. So focus on the Medicaid population is individuals served by Medicaid. So one of the things we're doing is we're characterizing a program. So we, these three core components I mentioned: training, resource and referral, consultation. And so we just did interviews with with all of the access programs throughout the country, with a particular focus on New Jersey, Washington, and Massachusetts. And we're understanding what are the program components. We're actually looking at how are these done throughout the whole country, funded by the network. And then we're also looking at, particularly in these three states, to inform this PCORI-funded study. So we want to understand how these programs are being implemented and what are the different ways and which ways work the best. So what we're doing, as I mentioned in this particular study, is we're looking at Massachusetts, Washington, and New Jersey. And, we're trying to figure out what is the engine, how do these work? So, and also which one's most effective. So Massachusetts and Washington, we really think of the engine of our access program as telephone consultation. That's the way we think these programs work. And our focus is on the frontline medical clinicians. New Jersey aims to increase access. I would say that they're different than the typical access program model. Their focus is on resource and referral. They're actually directly interface with patients. As I mentioned, providers individuals with lived experience or patients can't call MCPAP moms. They can call, we redirect them back to their provider because we're a provider-facing service. New Jersey takes calls directly from patients and actually rarely takes calls from providers. So their focus is to engage the patient, and they do mainly resource and referral. So we think that the way this works is we increase capacity by building frontline provider capacity. They're doing directly with the patient. Ideally, what we need is both of these things, so we're doing it for both. So what we're going to be looking at is, in what ways do these different approaches help and not help? And ideally, I think ideally we have, both patient-facing and provider-facing services. So we'll be looking at this which will then inform, policies around this, because we can't have it only through the providers. The more I do this work, the more that becomes clear to me, because there really needs to be no wrong door. So likely you need a combination of both, but that's what we're looking at in this study, is what are the strengths and weaknesses of each of these ways of implementing. And so I talked a lot about statewide programs, really high level. We're like the N of 72,000, for example, in Massachusetts. However, what I want to move to is talking about practice level interventions. So when we go back to this care pathway, MCPAP for moms really focuses on the first three steps: detection, assessment, treatment. I gave those examples. If we think about, Kai, her provider could have called, we would have helped figure out, okay, how do you detect depression? How do you assess it? And how do you start treatment? What MCPAP for moms and programs like it do less of, because we cover the entire state, often covering tens of thousands, in some states, hundreds of thousands of births. It's hard to really help individuals get down that whole depression care pathway and really build in addressing mental health and substance use disorders in a really proactive way, such that we're doing it just like we would for diabetes. If we think about diabetes as a parallel, it's very common to screen for diabetes in pregnancy and to do that. And when we screen for diabetes, everyone's screened for diabetes, and if it's positive, it's followed up, and we make sure we follow them until the blood sugar's under control. No one would ever screen one for diabetes and say, well, you have diabetes, or it looks like you may have it, gestational diabetes, let us know if you need anything. Or here's a number for an endocrinologist. Let me know if you need anything. You would actually make sure that you would keep monitoring it. You'd make sure that the blood sugar was under control. The goal with practical interventions is to make sure that mental health care and substance use disorder care are part of the workflow, just like we would do for any other medical illness that we know impacts birth outcomes and we know impacts child outcomes later on. So you might be wondering, well, that sounds lovely, but how do you do that? So what we did was we built an intervention that builds on these access programs to get more detailed at the practice level. So, and the goal is that we do this by leveraging existing resources to integrate this care into the protocol. So we focus on, screening, engage, treatment, which we do in MCPAP for moms as well, but we're really working to engage the practice in doing this. And we're also doing monitoring, so helping the practice not just start treatment, but also monitor until the symptoms until the illness is in full remission, until there's recovery of illness. And then also we do this through an implementation protocol. So, and what we found was that when we did a pilot study, this was my K award, we did a pilot study, and what we found, and what we're hypothesizing here, the thinking is that if you have MCPAP for moms, it helps people's depression. We focus just on depression for a while, it's going to get better. If you add these additional practice level interventions, their depression will improve even more. And this is what we found. What we found was that this is the MCPAP PRISM group, which is the proactive practice level intervention. They started in EPS about 13, which is a positive screen, to 6. Less than 10 is typically considered not a positive screen. So their EPS score went down by just over 7. So that was a pretty big difference. In the MCPAP for moms group, it went from 50 to 10, so less than about a little over a 5-point decrease in the depression score. So we see a 2-point difference. This was not statistically significant between the groups. This was an N of 30. It wasn't piloted. It wasn't powered to be significant. It was a pilot study. But what this says is that if we do a larger study, hopefully we're hypothesizing in a larger study, which we're at the actually tail end of, which I'll talk about, is that, we'll see this difference of differences. So again, MCPAP for moms helps. If you add on proactive practice level intervention, it helps even more. So what we do in PRISM, as I mentioned, this is the protocol, and we really focus on monitoring. And what we've done in this larger study, which is funded by the CDC, we bolstered up PRISM even more. And what we do in this is we help individuals screen for depression at the initial OB visit, 26 to 28 weeks, and 6 weeks postpartum, because these percentages are around when depression onset occurs. We also help them screen for bipolar disorder. So we really help them implement this screening as part of this. Then what we do is we help the practice develop a protocol to step up treatment with increasing illness severity. So if it's mild, the OB-GYN manages. If it's moderate, they manage with consultation. And if it's more severe, they manage with consultation or referral to psychiatry. And then we also have a navigator who helps the patients navigate that care pathway. So what they do is they have a registry of all the patients who had a positive screen on the depression screening tool, the EPDS, and then they follow them and they call them at several time points and see how things are going, and help them navigate that mental health system and help them provide support for them using a strengths-based approach, and help them get into care and stay in care and get better, essentially. So the navigators help both the patients and the providers navigate that care pathway. The OBs never have time to call the patients and see how they're doing. So the goal is that you monitor them until illness remission. So they're really functioning, the navigator, as a liaison between the patient and the provider. And you might be wondering, well, how do you do this? So what we do is we do a baseline assessment with the practices, actually using all those pieces of the care pathway. We look at detection, assessment, treatment, follow-up. We give them scores, and then we review the baseline assessment. We compare it to what the standards are and what the recommendations are, and look at whether what they're doing in their practice is consistent with the recommendations. And then what we do is we work with them to refine the goals. We establish a workflow. We literally have a workflow. We adapt it to the practice, and we help the practice to be able to think about, who does the screen, what happens if it's positive, who do they talk with, and then when do they call MCPAP for moms, what happens if they score positive on the suicide question, things like that. We refine the workflow, we come up with action steps, and then we have sustainment meetings. What we find is that, after they start, they do a lot of this, and then we have to sort of troubleshoot with them and address challenges as they come up. So, and what's fascinating about this is that we don't bring in any external resource to the practices. We do buy out time for a navigator from the practice, usually an MA or an RN or a social worker, to be able to have that, perform in that navigator role. But otherwise, the practice is doing all of this themselves. So what we really do is provide the structure for the practices to address this themselves. And it's amazing what they do with limited resources if we provide the structure for them to do that, because it's proactive. Medical systems are reactive. We help them get out of that reactive role to be able to be more proactive and really integrate this into their everyday care. So we are now in the no-cost extension year 6 of the study. We will have data to share next year, but so it's still early. But what I want to share is some of what we're seeing in the depression practice is pre and post implementation. So when we started this grant, and let me also clarify, you might be wondering, well, how are you testing this? This is a cluster randomized trial. So what that means is that we randomize by practice. So we have 5 practices that have access to MCPAP for moms. So they get a training and they just have access to MCPAP for moms. Then we have 5 practices that have this proactive practice level intervention, PRISM, and we're comparing them. We randomize by practice because these are practice level interventions. We then recruit women from the practices and we follow them until they're a year postpartum. That patient level data, we're finished with recruitment. We still have a few more patients going through, and because we have to follow them for a year, we'll be able to start, sharing that data in a less than a year now. What we do have right now is from our mid assessment, what this data is looking at the difference at the practice level between baseline and at the mid assessment. So depression screening in the first half of pregnancy before was 32%. In the PRISM arm, you could see it went up a lot to almost 100%. In the MCPAP arm, it went up, but not as much. In the second half, similar thing. You see it goes up a lot more in the PRISM arm. In the depression screening postpartum, they both went up slightly more in the PRISM arm, but nothing significant. Bipolar screening in the MCPAP for moms arm, none of the practices are screening. This is all based on chart abstraction. And in the bipolar disorder screening, none of 77.5% are screened. And in the monitoring the patients using the depression registry, 75% of the PRISM practices have a registry and are following depressions using this, and in the MCPAP for moms, they're not. So this is what we're seeing as far as when we did our mid-assessment with the practices. And then with the number of patients entered in the registry, you see the PRISM practices have patients registered on average, and the MCPAP for moms ones don't. So what this indicates is that we are changing practices based on this mid-assessment data, is that the practices and what the providers are doing are changing over time, and that we're seeing a difference between the PRISM and the MCPAP for moms arm. We do see some improvement in MCPAP for moms, but not as much as in the PRISM arm. The goal then is that then improves outcomes. So just a couple of notes I want to make about what we need to do moving forward is that we really need to build on these sort of interventions like PRISM and move beyond perinatal depression. So I mentioned bipolar disorder because we do screen for bipolar disorder in the PRISM study. And the reason for that is because of the women who screen positive for depression, up to a quarter of them may have undiagnosed bipolar disorder. So we want to help the practice of screening for bipolar disorder so that can be recognized. Also, more recent data shows that among individuals that have postpartum depression, almost 2/3 also have comorbid anxiety disorders. This was a large study that was done in 2013 by Kathy Wisner. They screened 10,000 women. They found that of women who screened positive, 23% had bipolar disorder, almost 2/3 had comorbid anxiety disorders. And then more recently, data is showing that up to 1 in 5 women have an anxiety disorder during pregnancy, the postpartum period. So really important that we're getting beyond depression. The PRISM study focuses on depression, but we really need to be integrating anxiety and also PTSD. I could tell you through MCPAP for moms, my clinical experience and the data, emerging data is consistent with this, is that, there's such a comorbidity with PTSD with a lot of, particularly as substance use disorders as well. So we really also need to be addressing post-traumatic stress disorder as a part of this. So what we did in response to this need, we created, with CDC funding, we developed a toolkit to help address perinatal mental health more broadly. This is publicly available. We can download it from our website. And as you can see, we screen for depression, bipolar, anxiety, and PTSD. And then we help develop algorithms for that. And then the other thing that we're doing is while PRISM was developed to be scalable, as you heard, we're still in there at the practice, having in-person meetings with them and really spoon-feeding them to help them do this. And so what we're doing now is in collaboration with ACOG, with CDC funding, we're revising PRISM to be more broad and scalable. We beta tested that with a practice in California recently. And what we basically do is we take the PRISM protocol, we make it more self-guided, and we basically have 2 implementation meetings versus all of those that I showed in that previous slide. And, is it as good? What we found, which reassured us, was that practices do make change. Do they make as much change as in PRISM? It's different, but they do make change, and they do change a lot of their practices based on this. What we learned is that practices really need the structure to do this, to do this. They need an implementation protocol and a structure because they don't know how to do this without that. And they need that protocol to be flexible and to be able to be tailored to their practice. So that's why we developed this virtual and lean. We have a virtual and lean approach where we provide 2 implementation meetings. We also have a self-guided approach to this implementation protocol that will be disseminated by ACOG. And then what we're doing now is we also have another cluster RCT where we're going to have several practices in this cluster RCT. And what we're doing is we're comparing 3 groups here. Usual care, which is usual, obviously, as it sounds, usual care. We're comparing that to e-modules, which we're developing in collaboration with ACOG, again, broadly focused on perinatal mood anxiety disorders, and a toolkit to toolkit e-modules and implementation and assistance. So one group is usual care, one group is toolkit and e-modules. Then the third group is toolkit e-modules and implementation assistance. And this is sort of funded by all of these different organizations. And so what we're doing in this new cluster RCT is we're testing the differential effectiveness. So what we're hypothesizing is usual care helps. If you add toolkit and e-modules, it's going to help. No, usual care, you see, you won't change practice. If you add toolkit e-modules, you're going to change it somewhat. If you add the implementation assistance to that, you're going to change it even more. We're not looking at patient outcomes here. We're looking at changing in provider practices based on chart abstractions of what we're seeing documented in the medical record. So that's another thing that we're doing, again, to make this more scalable. This is another cluster RCT that we're doing funded by NIMH. And as I mentioned, I want to come back to this at the end here before we, pause for Q&A, for questions, is that, again, we need to broaden our approach to address social determinants of health. So we have broadened to get beyond depression, which we're excited about. And I think there's a need. The data suggests there's a need, and this has been our experience in implementing these practices. What we need to do now, and I think where the field needs to go, is integrating in social determinants of health. So when we're screening for depression and anxiety, we're also asking about this and we're addressing them. It gets back to the same thing I talked about with depression and anxiety. We can't ask about these things and not have a response. So that's the challenge. And a lot of medical systems are starting to ask about this. I think what's less clear is how to respond. So really what I see as what the field needs is to be integrating in social determinants of health and active, proactive ways to address structural inequities and biases in care into these models. So I think that tells us that the medical model of treatments really needs to be done in conjunction with other supports, right? So when we think about this care pathway, there's engagement. We just had a group recently. We got some wonderful feedback from some community partners, and people said we want to see connectedness along this pathway. We want to see trust and social determinants, and we want social determinants of health addressed as part of it. And this is what we hear time and time again. And, we don't have a solution for that, but this is where we think the field needs to go. It's certainly where our team at UMass is working towards. And, I think there's a lot of opportunities and gaps here. So just to kind of, in closing, to revisit Kai, ideally, when Kai presented to her OB, she would have been screened in the first trimester. And someone would have asked her, do you have when they talked to her about listeria and eating unpasteurized cheese and all that kind of stuff that's actually pretty unlikely and really not very common, they would have told her about mental health. They would have let her know that depression is common and that they care about her mental health, and they're going to be asking her and talking to her about it because it's part of what's going to help her and her baby get the best start. And it would have been integrated as part of her obstetric care. And then she would have been screened a couple times in pregnancy. And when she started to get depressed in that second trimester, it would have been detected. And they could have called MCPAP for Moms or another access program, and they could have gotten guidance in how to manage that. And then they could have also helped refer her for resources in the community. So building social connectedness, referring her to a support group, also referring her. Ideally, what also needs to be addressed as part of this is also integrating in how do we parent. It's parenting and develop what needs to happen during development. We think it's intuitive, but it's actually not. That's another thing that needs to be integrated. Not that we focus on that, but that's another piece. And then, they would have referred her to all these resources. And if medications were indicated, they would have called us, so we even could have seen her if those other, community supports weren't enough, or she needed more support and she needed pharmacotherapy. And ideally, it would have avoided that situation that happened with her, so that we're proactively addressing this. And also during that process, they would have been asking about social determinants of health and been addressing those as well and connecting her with supports in the community as needed. So there's a lot of opportunities to close gaps in perinatal health care. And we talked about scalability. These things all need to be integrated into the EMR. We need to think about building the community capacity and actually bridging these access programs with the community. They're very medically focused. And I think that, we're working on that in Massachusetts with our collaboration with PSI, but we've got to integrate these with the community so there's no wrong door. And, as I talked about, a focus on health equity. So with access programs, all the individuals in Massachusetts in summary have access. And then we, PRISM and these other kind of models can help build on that to truly integrate this. And we need to be integrating these other pieces to really help people navigate the entire care pathway, both the clinicians working with them and the patients that they're serving. This is just some websites. If you're interested in our training and toolkit, these are all publicly available. And the National Curriculum Perinatal Reproductive Psychiatry is another great resource. Thank you to all the team who has been involved and our funders. I think we have some time for questions. Thank you.
Yes, thank you so much, Dr. Byatt. That was awesome to learn more about MCPAP and the work MCPAP for moms and the work that you've been doing. We do have time for Q&A. There is one question already been submitted from Melinda Kiley. I don't know if you can see it or if you'd like me to read it to you.
Yeah, I can't actually see them. I don't know why I can't see the questions. But yeah, no, please read them because I can't see. I'm looking at the questions, but I can't see it. Yeah, so please go ahead, just read them to me because I don't see them for some reason.
No worries, and please feel free to send in questions as you think of them. So Melinda asks, do you track family outcomes from phone consultations with Frontline MDs?
Family outcomes. That's a great question. So, yeah, it's a really good question. So I think this is one of the challenges actually with these access programs, because particularly the HRSA funded programs have a lot of outcome measures required. And the challenge with these programs is they're clinically funded programs, and not all of them actually interact with the patient. So our program in Massachusetts, we do call patients and we refer them directly to resources in the community. We have the resources to do that. Not all of the programs are that well funded, so several of them don't. So it's extraordinarily challenging to try to measure patient outcomes when our direct service is not necessarily with the patient. So we all those 12,000 women I said we've served, we haven't talked to all those women. A lot of them we talk to the provider, but we don't actually talk with the individual. And then it becomes challenging because the individuals we do talk to tend to be the ones that have the most significant needs because they're the ones we're doing the consult for, the most complicated. Then we get a really, really biased sample. So that is a wonderful question. It is something we're working on. We actually just applied for a grant to be able to look at how do we get at patient outcomes and what is a realistic way to do that. We're certainly getting at that with these other studies, as I mentioned, with PRISM, the PRISM study, the CDC-funded study. We are looking at patient outcomes. So we have done that through different ways by doing, research-funded studies. I think that we don't yet have an approach for integrating measuring patient outcomes into access programs, but we are working on it, and we actually have a grant to develop an approach to doing that in a way that's feasible. So it's a really, really good question.
Great, thank you. So we have a couple other questions, both from Jyoti. I'm going to, is there any documentation for the teleconsultations that you provide via MCPAP?
Yes, we do provide. We do provide documentation. Another good question. So what we do is, the access programs throughout the country do this very, very differently. So, for example, UNC, they have it in their EMR. Most of the programs have it separate than the EMR. The rationale for doing it separate is that we don't have a patient-physician relationship. So and it decreases liability. That's the rationale. But I think there's many, many ways to do this. So what we do is we have a database. It's separate than the electronic medical record, but we have a database. If someone calls, we document that. The resource and referral specialist answers the phone. They put it in my queue. I have like a list in my queue of patients that, are waiting for a consult, or the providers are calling, waiting for a consult. And then after I talk with the provider, I document that in that medical record. And then if I do a face-to-face consultation, I do put that on the EMR because at that point we have a patient-physician relationship. However, once I put that in the, in the EMR, I also put it in our records because, like, colleague at Brigham, for example, wouldn't be able to look at the UMass EMR where I do the note. So then we put the summary of that note into what we call MCPAP for Moms Live, which is our database, so that she can see it. The other reason we document is because, we've been around now for 7 years, and often, I did a call on Monday, and the person I did a consult for they'd been 4 consults on her before. So I went back and looked at the history to inform the conversation. And then I know what my other colleagues have talked about. Another one I did on Monday was a follow-up consultation. So I needed to go in and look at all the different consultations. Another psychiatrist had spoken to them between the last time I saw the patient. And so it really is important, I think, to have that database for continuity of care, because you don't want to be talking to people without knowing what the previous provider told them, and also knowing whether we've referred them for therapy or other community supports and what happened there. Because I'm able to say, oh, it looks like we referred her for X, Y, and Z, and then they have that information. So yeah, we do keep a database of it, and I think that's a really important piece of it to do that. It sounds like there's another question too, you said, Dee?
Yes, sorry, phone issues. Yeah, so we have several more that have come in, 2 that are kind of related, so I'm gonna kind of combine them. So one is about what's your strategy for provider engagement? Here in Ohio, we're starting to work on developing a seminal program, and then someone else offered up, just wondering if more outcome data would encourage more frontline providers to consult.
Yeah, that's a great question. So if this outcome data is really challenging. So we actually just had a network meeting yesterday, focused on program eval, and it was fascinating to hear what the programs throughout the country are like, what the stakeholders, what the people who are making these funding decisions care about. So what we heard from the programs, and what I'll also integrate our experience in Massachusetts, is, yeah, they do want to know patient outcome data. But I think the argument is that we're not like testing whether medication works or whether a psychotherapy treatment works, right? What we're doing is we're increasing access to evidence-based treatment that we already have evidence for. So we don't necessarily need to say that this improves outcomes, because it's a no-brainer to increase access to evidence-based care. Without these programs, people don't get care. There is no way there'll ever be enough psychiatrists to see the pregnant and postpartum individuals that need one. So you don't need to show that like increasing access to evidence-based mental health treatments improves outcomes. That said, we still are doing work to improve outcomes, because, and to show and to look at that. That said, it shouldn't be a barrier to implementing these programs, because these are treatments that work, and having increasing access to them is a no-brainer. So that's one piece of it. The other piece, I would say, and we don't have that right now, and all these programs, there's 17 of them throughout the country, none of them have patient outcomes. So I think you can get it funded without that. And that's been successful in almost half the states now in the country. The other thing I would say is that what I find that the funders care about is they want to know, are people using the program? And so they want to know what helps us in Massachusetts. What these other programs talk about is, do providers like it? Do they find it helpful? Is their practices changing? Are they providing care more? Do they feel more comfortable treating mental health and substance use disorders? And have you enrolled practices? So one of the metrics we use all the time in Massachusetts is, we've enrolled 78% of the practices in the state. There's 72,000 births. That covers thousands of births throughout the country. They care about that. If you're available to help the providers and you're serving a lot of individuals, that helps. And I would say the other thing that really matters is, to what extent it's being used. And also what matters is testimonial. If you're trying to get a program funded and you can have a provider tell a story and come up and provide a testimonial about how they didn't know what to do, and then they, called, and then they knew what to do, and the patient got better, that's worth its weight in gold. My experience when working with policymakers and funders is a lot of what drives these decisions is data helps, but what drives them is pulling at their heartstrings, and what drives them is affect. It's patient stories. And the other thing I would say is having stories and testimonials from individuals with lived experience, either that haven't gotten care before the program or that had an experience with the program where they got care. Because it's going to be hard to get systematic patient outcomes. That's a long way down the line. I agree it should happen, but we don't want that to be a barrier. But testimonials from clinicians who've been served by the program and individuals with lived experience have been served, that makes all the difference. And also partnering with advocates and individual experience makes all the difference in getting programs funded. I think none of this national stuff would have happened without the many, many advocates out there, many of whom have lived experience out there banging the pavement. And it's particularly what helped get this legislation passed. It wasn't me talking to, Congresswoman Classen Clark. It was Jamie Balsito, a woman with lived experience who is, really, really has a very powerful voice.
Thank you, Nancy. One last question, unfortunately, before we have to break. Such a great presentation. Every time I hear you present, I learn something new. Can you please say a few words about the costs involved in doing resource and referral? I think you said that Washington doesn't do the resource and referral piece due to cost. So I'm wondering what the sources of costs involved in doing that piece, resource and referral, are. Thank you.
Yeah, that's a great question. So I think you're really looking at you're paying for the person's salary. So I mean, that you're really covering. It is less. So the majority of the MCPAP for Moms budget tends to be the psychiatrist, because there's you're covering that, and that's that's one piece. But the resource and referral is also, I would say it's probably 50-50 with where the budget is. And with the resource and referral, it's a critical piece. I think you can't underestimate how important that part is, because it's a lot of why people call. They may call and not want to treat the patient, but if they can call and say, I have a patient and they can do a therapy referral, it often is that low-hanging fruit why people can call in the beginning. And I would say that what you're really covering with resource and referral is you're covering someone's salary and their fringe. So that's how you can kind of back up into that budget. And we have, we tend to have LMHCs, because we do find that, or an LCSW, someone with clinical experience, because we do find you need someone with clinical experience. And my experience has been that it's worth the extra funding to fund someone that has that clinical experience, because that clinical experience is huge, because they're often on the phone with individuals that are experiencing symptoms, and having that clinical experience to know how to manage that is really, really critical. But that's a lot of what the budget is, paying for their time. And it's basically paying for their salary and their fringe and so forth. And, we manage with 2 resource and referral specialists for a while. Now we have 2.5. We now need to expand to 3, because we just keep getting busier. So hopefully that helps answer the question. But it is well worth it, I find. And I think that it helps with utilization when they know they can call for referrals to therapy, especially in the beginning when they may or may not have wrapped their minds around providing direct treatment yet.
Well, thank you very much. And thank you everyone for attending today, our iSPARC webinar with Nancy Byatt. We really appreciate you spending your afternoon with us. Our webinar will be posted on our website, the recording, as well as Dr. Byatt's slides. And the URL will be sent out in a week or two to let folks know where they can find it. We do have a survey to let us know how you did, what you thought of the webinar. So if you could fill that out, we'd really appreciate it. And I hope everyone has a lovely rest of their day. Thank you.
Thank you. It was a pleasure to be here. Thanks for coming, everybody. Bye.